Take it away.
Good afternoon or good morning, depending on where you're joining us from. I'm Chris Konchak. I'm Senior Director of Traffic Safety and Government Relations for Responsibility.org, and we are thrilled to have you all joining us for Cars Connect, Mental Health and Substance Use Screening for Drunk and Impaired Drivers. This webinar is a great opportunity to learn more about the link between mental health and impaired driving and what we can do to reduce the amount of recidivism with impaired drivers. Next slide, please. Responsibility.org was founded in 1991 by America's leading distillers. We're a national, independent, not-for-profit organization working to promote a lifetime of alcohol responsibility. And next slide, you can see some of our board members who are actively involved with our work, just making sure that we have the resources we need to do the great work that we do and make it available to the community for free. Next slide, please. We focus on three different areas at responsibility.org: to eliminate underage drinking, to eliminate drunk and impaired driving, and to empower adults to make a lifetime of responsible alcohol choices. And we have multiple programs in all of those areas. Again, they're all available for the community to use, and we welcome you to look at responsibility.org and take any of the resources that are there, to use them, to reach out to us if you have questions about them, and to help us accomplish all of the goals. Next slide, please. For a long time, Responsibility.org has been concerned about mental health and impaired driving. And almost 15 years ago, we learned about some research that Harvard and the Cambridge Health Alliance were doing related to the link between impaired driving and mental health. At the time, what I understand is that Harvard came to us with a list of possible ways we could be helpful, and it was determined that with our help, they would start working on CARS, the Computerized Assessment and Referral System, which is a great screening and assessment tool that can be used to screen impaired drivers. And it was specifically designed for that group of people. And over the years, that tool has been updated, has had changes made to it to make it current, to make it with all of the newest research and as helpful as it can be for the community. At the same time, a couple of years ago, Responsibility.org and the National Alliance to Stop Impaired Driving realized that this was a bigger issue and needed more people involved. And that while people were talking about it, they weren't really coming together and working on it as much as we wanted them to be. And so we formed the Mental Health and Impaired Driving Working Group, and we pulled together a lot of leaders from national organizations to help identify what resources are needed, how we can be most helpful to communities, to all different segments of the community, to provide resources and materials that help us reduce impaired driving by figuring out that link between mental health and impaired driving. And then at the same time, Responsibility.org was looking just at mental health in general, not specifically related to impaired driving. And they created a section on mental health resources and for individuals and families. And you can find that information on our website as well. And then finally, also around the same time, we determined it was time to take CARS to the cloud and make it much more accessible and easy for folks to use. And so Cars Connect was created and launched about a month ago. And we're here to talk about that today and give you all the new information on Cars Connect, tell you how it's a little bit different than Cars, just streamlined a little, and how easy it is for you to use. Next slide, please. We have two speakers today, Dr. Sarah Nelson and Julie Seitz. Dr. Nelson is the Director for Research at the Division on Addiction with the Cambridge Health Alliance, a Harvard Medical School teaching hospital. And she is truly the brains behind CARS and really can answer all the questions related to this great tool, how the research led to its creation, and how it can be used in your communities. And then Julie Seitz is the project director for with the Impaired Driving Solutions at All Rise, and she works as a technical support to courts across the country as they're looking how to work with things that are available, how to best provide treatment and resources in specialty courts. And so she's here to sort of give you information on how to put CARS to work and why it's so important that we use it. And we will take questions and answers at the end when everyone's finished their presentations. So if you put your questions in the Q&A section, we'll get to as many of those at the end of the webinar. I also should mention that both Julie and Sarah are members of the Mental Health and Impaired Driving Working Group that I mentioned earlier, so it's great to have them as resources on that group. With that, we will move on to Dr. Nelson in the next slide. All right.
Thank you so much, Chris, for that kind introduction. I think it's important to note, too, that I can give the academic theoretical approach to all of this, but Julie really provides the valuable kind of hands-on how you implement mental health screening with impaired drivers, and all of the more concrete details as well. Thank you all for making time for this webinar. As Chris said, I'm going to provide an introduction to CARS Connect, but I'm also going to provide more basic information about mental health and impaired driving and why it's so important that we screen for mental health issues among impaired drivers and DUI offenders. Before I get started, I want to recognize in particular that Responsibility.org has provided primary and ongoing support for the development of CARS for almost a decade now. And that's saying something, being able to fund and collaborate with academics. We're a sort of slow bunch. And so all of the work that we've completed would not be possible without them. And on this slide, I've also listed the other funders that the Division on Addiction receives grants from. So CARS is short for the Computerized Assessment and Referral System. It's a screening and assessment tool that we developed and tested for use within DUI programs. It's been many years in the making, and it's been available for free download at our website for several years. But as Chris said, this month we are finally releasing a new version of CARS, CARS Connect, and finally putting it in the cloud. So CARS Connect is a web-based version of CARS. It still provides comprehensive screening for 17 mental health conditions, as well as risk factors for those conditions, information about impaired driving history and risks. And it provides tailored reports about clients' mental health symptoms, impaired driving risk factors, and other relevant experiences, and then prints out a list of resources tailored to clients' geographical location at the end. It can be directly administered to clients or self-administered via a link. But to begin, as I said, it's important to understand what led to the development of CARS and CARS Connect and why we believe there is a need for mental health screening tools in programs that serve impaired drivers. So I'm going to go into that now, and then we'll talk about the tool itself. So let's back up for a second and consider more generally how mental health and addiction relate. If you take kind of any group of individuals who have an addiction, whether it's alcohol use disorder or drug use disorder or gambling, and you start assessing them for other issues, what you might find is that there's a subgroup that suffers from manic episodes or has bipolar disorder. You might find others who have experienced traumas or have PTSD, others with depression, others with anxiety disorders, And there may be a whole host of other disorders you're not assessing for. And what you're left with is actually a small group in the middle that's actually suffering just from addiction. And this is what we find quite regularly in the data. When you look at individuals with addiction, there is high what we call psychiatric comorbidity. So a lot of co-occurrence of other mental health issues. Jumping back to our impaired drivers, I like to show this chart. It's basically showing the percent of motor vehicle fatalities that are alcohol related from the 80s to essentially today. I think 2023 is the last year that NHTSA has data for. And what we see is initially a reduction, which is great, over decades. And then the chart begins to plateau between 2006 and 2017. And then finally, we see a little bit of an increase in the past few years, and then a little bit of a reduction. The main point that I want to make here is that the prevalence of alcohol-related fatalities look better today than it did in the 80s, but DUI continues to be a devastating problem, and the plateau is quite concerning. Over time, we've taken a lot of steps to reduce DUI and DUI reoffense. That includes information campaigns, roadside checkpoints, education, licensing sanctions, et cetera. But when we look at the research around some of these initiatives, they aren't quite as effective as we might hope. It suggests that in some cases, they're serving as Band-Aids, but not addressing the problem fully. And you can think about ignition interlocks, where really effective when they're on, but often rates will rebound once you take them off. And so this all really suggests that some DUI offenders simply aren't getting the message, right? They aren't deterred in the ways that others have been. And there's work that suggests that people who drink and drive frequently actually are just as educated about the risks and the consequences as others. So that's not what's going on. And so we hypothesize that the reason we are seeing this plateau and that repeat DUI offenders aren't getting the message is not lack of information, but because of underlying issues that are compromising their ability to change their behavior. And we hypothesize that that was primarily mental health issues. And we know that about 2/3 of first-time impaired drivers self-correct, and about, I think, less than 5% account for 80% of impaired driving episodes. So it becomes really important to identify that third who don't self-correct and what issues are leading to extensive recidivism for some repeat DUI offenders. So think about repeat DUI offenders for a moment, individuals who are arrested multiple times for DUI. What percent of repeat DUI offenders do you think have experienced and qualified for mental health disorders in addition to alcohol or drug use disorders in their lifetime? I'll give you a minute, get kind of a percent in your head of what you think it might be. And we find that that rate is about 45%. And that's from one study, but other studies find similar rates, right? So we've got close to half who can be diagnosed with an additional mental health disorder that is not alcohol or drug related, in addition to alcohol or drug use disorders. That's a lot. And so we did a set of studies where we were essentially looking at repeat DUI offenders compared to the general population and looking at what the prevalence of different disorders were in that population. So this chart that is up right now is showing one of those first studies. It was a study of about 800 repeat DUI offenders who were in a 2-week residential program that was part of their sentence. And then we compared their results to the general population. So the blue bars here are the DUI offenders. The green bars are the general population sample. Not surprisingly, we see that the repeat DUI sample has significantly elevated rates of alcohol and drug use disorder. But you also see elevated rates of conduct disorder, bipolar disorder, PTSD, generalized anxiety. And like I said, about half of the sample qualified in their lifetime for a psychiatric disorder that was not a substance use disorder. Results are really similar for past year, but they're muted. But one thing to notice is that PTSD is still quite elevated, even a past year diagnosis in this population. So past traumas of all different types are quite prevalent, and PTSD is elevated among repeat DUI offenders. In our more recent studies, we didn't conduct a full diagnostic assessment, but we screened for these same disorders. And so any rates you're seeing here look higher because these are kind of screening results, not full diagnoses. And here we're looking at first-time DUI offenders compared to repeat DUI offenders. And we were looking to see if there were differences between the two. And as you might expect, repeat DUI offenders are much more likely to screen positive for lifetime mental health disorders than first-time offenders. And I put first-time in quotes here. We'll come back to that. In particular, drug use disorders, PTSD, and bipolar disorder were significantly elevated in repeat DUI offenders compared to first-time offenders. But I want you to note that a significant proportion of first-time DUI offenders also have mental health issues and comorbidity. And that's important to consider when we're thinking about how best to target mental health screening for impaired drivers. Again, the results are very similar for past year, but those rates are obviously lower. And then you can see, I'm going to blow through these a little bit, lifetime screening results for other disorders we assess. We're still seeing that same pattern, higher rates in the repeat DUI offenders compared to the first-time offenders, and the same thing for past year. One important disorder we did notice is ADHD, so attention deficit hyperactivity disorder, is both elevated among repeat DUI offenders, and we have also seen some evidence that it might contribute uniquely to DUI arrests and events. And that might be kind of combining the impaired driving piece with also kind of risky driving that goes along with ADHD in some cases. So that's kind of a disorder we want to do more research on. And finally, when we look just among these individuals past 30 days reports of symptoms, you can see those repeat DUI offenders are having more difficulty with impulse control related to violent behavior and higher rates of suicidal ideation. And we actually have a paper on DUI and self-harm as well, showing that for some offenders, DUI can actually be considered a type of self-harm and something to pay attention to. And again, where screening becomes very important. Coming back to that question of first-time offenders, question that hopefully most of you know the answer to, which is how many DUI violations occur for every DUI arrest, meaning, about how many times do people drive impaired before they might be arrested. And using data from self-report and FBI statistics, you usually find that it's about between 80 to 100 plus times that an individual has driven impaired before ever being arrested for DUI. And that's really important because that means when we're talking about first-time DUI offenders in the system, they are very likely not first-time impaired drivers. And so that's important to consider also with screening. The last population I want to highlight before we talk about kind of screening itself is female offenders. So when you look at DUI offenders, and especially repeat DUI offenders, it's usually about a 70-30 split, meaning 70% are male, about 30% are female. Rates of women engaging in impaired driving activities are increasing somewhat. But what's important to notice is that among women who are getting arrested for DUI, their mental health profile is actually much more severe than male DUI offenders. So if we're looking at repeat DUI offenders and we look at the women, they are much more likely to have what I've circled here, 3 or more additional mental health disorders beyond alcohol use disorder or a drug use disorder. So this is a unique population that also deserves further consideration. And finally, I guess the question becomes, you can show that mental health and impaired driving go hand in hand, but the next step is, do we actually know that the mental health issues are potentially causing the impaired driving behavior? And the answer to that is yes, to some extent. So I want you to focus on this chart. This is from our original sample as well. And so what you see here is the blue line just tells you in our sample of repeat DUI offenders, what percent of the sample qualified for 0 mental health disorders, 1 disorder, 2 disorder, et cetera. And that blue line, you can see the majority is 1 disorder, and then it kind of tails off from there. More importantly, if you look at that maroon line, it's almost linear, right? It's going up and it's increasing. And what that means is for these individuals, the percent with a given number of disorders who reoffended, right? So at 0, we've got 0 because very few had 0 disorders. 1 disorder, about 10% of that group had a DUI reoffense. 2 disorders, closer to 20%. 3 disorders, 20%. If they qualified for 5 disorders, about 30% of that group reoffended. So you can see the more mental health comorbidity people have, the more likely they are to reoffend. Looked at it slightly differently. Here, what we did is we divided our sample into 3 groups. That blue line are individuals who have no mental health disorders other than alcohol use disorder. The green line are people that only have substance use related disorders. And then the red line are individuals who qualified for another psychiatric mental health disorder. This is what's called a survival curve. The fact that that red line is decreasing over time means that those individuals over time are more likely to recidivate, right? So we're looking at recidivism there. There's fewer and fewer of the sample, less and less of the sample that has not recidivated in that red group than in the others across time. So it's another chart that is simply showing that mental health really does seem to some extent, predict DUI recidivism. So we have established mental health issues contribute to impaired driving and reoffense. So the next step is to talk about screening. Why should we screen? When should we screen? How should we screen? And Julie will do a much better job of this than I will, but I'm going to start with a couple points here. The first is sort of our theoretical model when we were developing CARS. So what we want to do is we want to identify mental health issues that influence DUI behavior. We've kind of done that among repeat DUI offenders. And we know that when you get treatment and help for those issues, DUI decreases. So what we're hoping to do with screening is identify these issues, and that is a first step toward intervening to reduce their impact on impaired driving. Because what we're doing is we're hoping to get people into additional treatment or help of some kind that then reduces the impaired driving by treating those underlying issues. So that's really the model that we're following here. A lot of times I get asked if CARS is, a risk needs assessment. I would say that it's not in the traditional sense, because what it's really focused on is that mental health piece. And we know that mental health disorders are a major risk factor. And so our primary purpose is to identify those issues and identify treatment needs. And then secondary use can be used to kind of predict risk in some way. Next question is, when should we screen and who? A lot of times, many months can pass between the time that an individual conducts an offense or is sentenced, the time before they begin mandatory alcohol treatment. In our first study, we were assessing people who were supposedly going into treatment for their arrest, but for some of them, that was almost a year later. So all kinds of things had changed, and we missed all kinds of windows to identify these issues and begin dealing with them. So really, the best time is as soon as possible, and potentially multiple times, because some of these, the state someone is in is very different at the time that they encounter law enforcement to a judge to treatment. But I think all of these are screening and assessment opportunities. Why don't we screen? There are several barriers to this type of screening. One is awareness, and we're hoping to kind of help with that year to year. Another is training. So a lot of times individuals working in programs for impaired drivers do not have the training to identify mental health issues beyond substance use. There's been a lack of user-friendly tools for that purpose, and time and resources tend to be a big one as well. So really, DUI program providers don't always have the training or resources to identify and address mental health issues among their clients. And that really led to our development of CARS itself, was trying to provide a tool that could be used by individuals who are not necessarily clinicians to provide a really thorough and comprehensive screening for mental health issues. So the tool provides user-friendly kind of reports that can then be shared between counselors and clients. When we first developed CARS, we partnered with the Harvard School of Public Health, who had developed a very thorough, comprehensive assessment that they used in research called the Composite International Diagnostic Interview. So we partnered with that team to adapt some of those questions for CARS. CARS screens for 17 mental health disorders. It assesses both lifetime and past year occurrence of those disorders. It includes both an interviewer-administered and a self-administered version, depending on your needs. Importantly, it can be administered by non-clinicians. So our current version should take less than 1 hour to complete. Our original version of CARS, as many of you know, has, up to 15 modules that can be turned on or off and could be anywhere from 1 hour to 4 hours. So we're really looking to streamline with this current version and kind of retire those longer versions going forward. CARS includes questions about mental health symptoms and disorders, but also about treatment, stress, domestic violence, and other life experiences. And then it generates a report that has those screening results, treatment history, risk factors, and geographically targeted information about mental health resources. Very briefly, in the beginning of our work, it was really important to us to have users involved from the very start. So we wanted to avoid a helicopter approach of just kind of coming in, dropping a tool and telling people they have to use it. So we worked with, I think, kind of 10 different sites and programs who treat impaired drivers to have them test the usability of the tool. And then we kind of iteratively adapted it to make it as usable as possible for them. And I think the most important adaptation we made was to create a standalone screener. So when we first created the CARS, we had a screener that then dumped you into different modules, and that's the version that could take 1 to 4 hours. We found that screener, which was adapted from the Harvard School of Public Health tool, wasn't very kind of specific. Like it would ask you, have you ever been sad? And that was the positive screen for depression. You can't have just that question if you want a screener to stand alone. So we made serious adaptations. So now the screener itself can stand alone, and I'll talk about kind of our work to validate that. We also kind of created versions that clients can complete themselves. So you can do it either as an interview administered version or self-administered. There are pros and cons to each. We created a Spanish version and updated CARS to reflect kind of the most current DSM diagnostic criteria, so DSM-5. We did create a version of the CARS screener with additional assessment items not specific to DUI populations, and that we called CARS NH. And so what we have done now, CARS Connect is a streamlined version of CARS, and it's adapted to run as a web-based application. So basically, it is that standalone screener module plus an impaired driving module that is optional that gets triggered by your answers to those questions. And we'll go through that in a minute. This was really necessary based on feedback we got about people having difficulty installing, downloading, and using the tool that way. By having it on the web, there are a lot of benefits. It's easier to access and use, and more streamlined to kind of create new versions and adapt as well. This is just a little timeline of kind of where we have been and where we're headed. You can see on that first version, Harvard School of Public Health was involved with that. And then responsibility.org and we at the Division on Addictions created these other versions. And finally, we partnered with SpinUtech, which is a tech partner to adapt CARS for the cloud. So you do not need to memorize this chart. You will not be quizzed on it later. I like to include it because then if you get a copy of the slides, you can see kind of all the detail that you want. The biggest take home from this chart is this is a study we did to see if our screener itself could kind of stand alone as a diagnostic instrument in a way. So what we're doing is we are testing whether the CARS screener does a good job of identifying mental health disorders that someone might be at risk for. And you do that by comparing your screening results to a full diagnostic assessment and those results. And we did that in both a large general population sample that we already had data for and in a DUI sample. The main take-home point is that we have very good sensitivity and specificity for most of the disorders that we are assessing here. And the only exceptions to that are if you're trying to kind of distinguish panic attack from panic disorder. So some kind of minor adjustments there. And then originally we were trying to differentiate major depression from persistent depressive disorder. And we kind of determined it works better if we just kind of assess for depressive disorders more generally. And we have a paper on this as well for anybody who wants more information. So the other question that has come up a lot lately, there's always this talk about, oh, but is it validated for DUI populations? And I think that might have just come across the chat. I'm trying not to monitor it too much, but in general, I think it's important to be very precise with what we mean by that. So validated means, is it measuring what it's supposed to be measuring in its most general sense, right? Are you actually capturing mental health symptoms that are impairing functioning? So the slide I just showed you, we are showing that we are capturing mental health risk for mental health disorders. The next question is it validated within a specific population? And so that's asking, is it measuring what it is supposed to be measuring in that specific population? And we're finding that yes, among DUI offenders, the same thing holds, that these symptoms of mental health disorders, what we're predicting does kind of fit with when you assess fully for mental health disorders. So it is validated within DUI populations, but there are a couple other considerations that I think are just important. Even if, this is about mental health, it's a valid tool to use, you want to understand as you're thinking about your population, how common are these conditions in the population, and then how much do they affect risk for DUI? And I think that we still need to do further work. Like I said, we know that the more mental health disorders and symptoms you have, the more your risk increases for DUI recidivism. But figuring out which specific disorders relate to that, the data are not as strong there, other than that one ADHD finding I was mentioning. So it's hard to say, oh, it's if you have PTSD, you're more likely. It's more if you have a lot of mental health issues going on, not surprisingly, you're more at risk for continuing to drive impaired and be arrested for impaired driving. Okay, so from there, I want to move on to CARS Connect, tell you a little bit about it, and then I'm going to kind of go through very briefly kind of some screenshots and kind of explain how you get started using CARS Connect. Those of you who have already used CARS, the questions are very, very similar. As I said, it's streamlined, so it's basically the screener module and then impaired driving questions, but the look feel is a little different and simpler in some cases. So CARS Connect adapts a streamlined version of CARS, which actually we call CARS SC. which you will still be able to download from our website if you cannot use a web-based version for some reason with your organization or anything like that. So these are, in terms of the questions and the reports, these are the same. It combines the screener and an impaired driving module, like I said. It has an enhanced report. Some of you will have noticed some of these features in CARS MH if you were using that. That was the mental health one. But we include additional feedback about kind of psychosocial risks and other issues going on for individuals. Simplified user interface and setup, I would say that is 95% of the support calls we get are in relation to getting CARS set up. So this is what we're really looking to streamline and help with. And obviously it can be accessed online. It still screens for all of the same disorders that it did before. So we have all of those disorders listed. And then you're also seeing, you get information about suicidal ideation, domestic violence, a little bit about physical health, life events and triggers, criminal history, impaired driving behaviors, risky driving behaviors, and substance use behaviors and motivations. This slide is a little hard to see, but again, I like having it here for a reference so you can have these slides after the fact. And this compares kind of our different versions of CARS. So you can kind of see how they are similar and different across all of these versions. And this will be up on the website as well. Okay, so we are doing just fine on time, which is great. CARS Connect. Okay, so the first thing that you have to do is get your organization registered to use CARS Connect. Currently, the way we are doing that is basically through a form you're going to fill out. So there's a link, and currently it resides at our website, CARS Training Center. I think that link might end up being available elsewhere as well. You go in there and include the information for your organization. And then within the week, you'll get an email that you've been set up within CARS Connect. It's important to note that, like CARS, the structure of this is you are registering an organization, and then within the organization, you can have as many users as you want that you set up to use CARS. So if you're in an organization that's already registered for CARS, you can skip this step and you can have your administrator just kind of add your information to the organization's account. From the email, you'll select the link. This just has additional details. So again, you can reference these slides for if you don't have an account, and then you complete that requested information if you are setting up the account for your organization. When you first log in for your organization, you will be logged in as an administrative user, and this gives you the ability to set up additional accounts within CARS. Basically, CARS Connect is set up so that administrative users have an extra tab at the top called Agency Admin, and that gives them access to some of these other features where they can set up additional users in their system. Here, users are people who are going to be administering CARS to their clients. If you are, when I see a question, I'll try to answer it. If you are a sole provider, then you would be both the administrator and the user for your account. So you could certainly set it up if it's an individual user. The caveat is just that if you're in a big organization, we don't want multiple people trying to set up the organization's account, or else there'll be duplicates in the system. So here, it's bigger. You'll see, again, you can kind of set up these evaluators who are your additional users within the system. And you can send an invitation link to anybody that you want to grant access to the system as a user for your agency. So no more emails where you have to get some kind of verification code. This is pretty straightforward. The only issue is making sure users know to check their spam folder if they don't get an email right away, but there shouldn't be anything blocking anything in that way. Oops. There we go. Okay, so if once you are in Cars Connect, so this would be the website that you're on, your case list is the equivalent of kind of all the assessments that you have conducted. So if you're going to conduct a CARS assessment with a client, you would click Create New Case, and that's going to bring you to kind of a new assessment window. In the first questions that are asked, again, some of these are similar to what you've seen before. One is the client ID. This I want to make an important note of is important because this is on the web. We are asking, this is set up so it doesn't collect identifying information to improve security. So anything to identify the client is simply through that client ID. It should be whatever ID your program uses, and it should be one you can link back to the client within your organization. Because this, like CARS, will be generating kind of a PDF of a report that you can then kind of file with your client's information. The next important question in here is whether the assessment is self-administered or interviewer administered. For CARS Connect, we don't have completely separate versions. Instead, we have instructions that both client and counselor could use. And what's important is if it's self-administered, you will end up sending a link to your client so that they can kind of administer the assessment remotely themselves. And finally, we ask at the very beginning if the assessment is being completed as part of a DUI court or program. In this case, this is an important question because this guides whether the optional impaired driving module is turned on or not. So if you say yes to this question, there will be a set of questions after the screening module that asks all about impaired driving, criminal behavior, etc. Some of the questions those of you who have used CARS are familiar with. So if you say no to this question, it's not going to ask about impaired driving behaviors, and it's not going to generate output about impaired driving risk. Once you begin, everything will look quite similar to CARS itself. So you're going to work through these questions. You will notice, for those of you who have used CARS, that the ordering of questions is somewhat different. So every single question about a given mental health domain will be asked before kind of it moves on to the next domain. Like CARS itself, the assessment does have warning windows. These will pop up if a client expresses current suicidal ideation or current lack of safety at home. And you're going to get a pop-up like this, and you basically need to decide whether you want to continue with the interview at that point or exit out and initiate a crisis plan for your organization. Another thing CARS Connect has is in some cases a little information button. So this is a question you'll see, SC60F is a question that's asked kind of the interviewer once the client has left. And for example, here, if you were to click on that information button, you would get more detail about kind of how to rate functioning for that individual. So that's just another little feature within CARS Connect. If I had selected self-administered on that first question, it would have taken me to this screen. And you can see here it says copy this link and send it to the client if you would like them to self-administer the assessment. And the only caveat here, and it's listed in the instructions, is if the client's accessing the self-administration link on this computer, then you want to log out of CARS before using that link so they don't have access to the rest of your system. Once you have completed an assessment with a client using CARS Connect, it will automatically bring you to the raw data report. So this isn't your typical CARS report, but this is a report that basically shows every single question that could have been asked and what the responses were. It'll have an NA if the question wasn't asked. You will notice that in every question that you can ask during the assessment, if it's not self-administered, there's also a box for evaluator notes. So you can add notes to any question if you want to clarify, and then those will print out in that raw data report. To access reports, basically the next time you go into CARS or the second you go to your case list, you will see for, specifically for if you're an administrator, you can see it for all of the users in your system. If you are a user within an organization, you will see your own cases. You see the client ID number, and then you see options for review or report. The review is just that raw data, like all the answers that I just showed you. If instead you click the report button, you will get the CARS report, which will look exactly the same as the ones you guys have used in the past. And what it will do is when you click that report button, it will automatically download your report to your downloads folder. And again, that report looks very similar to what you all are familiar with already from CARS for those who have used it. Okay. Another neat feature of CARS Connect, it has a referral directory. So the same way that we print out your 5 closest resources when you complete CARS, whether you complete the downloaded version or another version, this will do that as well. But it also has a searchable referral directory. So you can just go into the referral directory button and you can enter any zip code and it will kick out kind of all the resources that we have in the system for that zip code. And it will also let you add resources right there on the web. And that becomes part of the larger web database, which is really nice. Important notes. So CARS Connect is a separate version of CARS. It does not interface with other versions of CARS. So I saw in passing, I saw some questions come through about, indicating how many computers you use. This is CARS Connect is different than the versions that you've used before. It is accessed through carsconnect.org. And so if you are a user of CARS, you will need to newly register for CARS Connect. It is separate. It does not, as I say, it doesn't request any identifying information about the client, but includes a field for client ID. This helps protect the confidentiality of the client's information. And again, it includes that question about whether the assessment is being completed for an impaired driving program or court. Answering yes to that question activates optional sets of impaired driving and criminal history questions. And if you answer no, those questions will not be asked. And I want to leave you with, those of you who have heard me speak have heard this quote before, one of my favorite quotes from Carl Menninger. Treatment depends upon diagnosis, and even the matter of timing is often misunderstood. One does not complete a diagnosis and then begin treatment. The diagnostic process is also the start of treatment. Diagnostic assessment is treatment. It also enables further and more specific treatment. Even just in my work as a researcher, a lot of times when we're interviewing clients, a lot of them will say, this is the first time anybody has asked me any of these questions. This is the first time anybody has kind of interacted with me about these issues. So simply asking the question is sometimes a start in itself. And these are several resources we have. Again, we will share these slides after, and you can have access to all of these resources that we have for CARS Connect and CARS more generally as well. And I believe with that, I will be passing it over to Julie. Thank you.
All right. Thank you, Dr. Nelson. This is a really, really difficult act to follow for a number of different reasons. The data is so compelling on the necessity for understanding who our impaired drivers are. Having brilliant and validated and useful tools are what arm us as practitioners and clinicians in the field on how to effectively create pathways for intervention and reduction in recidivism. So I always start with a couple of things like basic understanding, basic knowledge we have to have, which I think, and Dr. Nelson obviously will be a part of these larger conversations with us when we get into some of our questions. I think we can all agree upon. Having effective screening is what allows us that opportunity to know if someone is screening positive to further assess and evaluate. If they warrant further assessment, that creates the diagnostic opportunity to create the opportunity for placement and then a treatment plan. So said another way, what we're really aiming to do is have a better understanding of who the impaired driver is in front of us, and what would be most effective for creating a pathway of interventions. Now, I think we have lots of different folks here from different organizations, different, just the areas of the and fields in which we're working in impaired driving. But I think we can all agree upon having a better understanding and more individualized responses to how we approach the impaired driver creates better outcomes and better pathways. So ultimately, this becomes about screening that helps us determine whether assessment is needed. That then determines what placement is, and that then determines what the treatment plan is. My favorite thing to say, and to which Dr. Nelson was alluding to in her quote, is, hey, some of the treatment works for some of the people some of the time. And so we need to know what that is, and we need to do that through screening and assessment tools. Why is this important? Well, we know that there are a number of folks, in fact, over 38 million Americans drink too much. So we identify that as risky or hazardous, harmful drinking. 9.4% of those report past month use of illicit drugs. So we have about a little under 10% using illicit drugs. And 2.5% of those are using prescription medications that was not in a way that was prescribed. What I will say is that when we think about this, most healthcare professionals and even justice legal professionals maybe don't even have the adequate training on screening. We have these tools, we have processes in which we do that. I've shared, if you've heard me in the last year, I apologize, but I've shared this recently. This winter I went in for my annual exam, and I had a screen and all of us that have had some type of exam, whether it's with your dentist or your primary care, have likely had some kind of alcohol, tobacco, and drug use screenings. And when I was sitting at the computer, next to the computer, and the nurse was in there with me, she looked over at me and said, "You don't do drugs, do you?" Well, I mean, gosh, when you say it that way, I guess I don't really want to tell you. The whole point in all that is I know that's not what the questions were in the screening tool. And it's this lack of adequate training, this lack of understanding on how to utilize the tool, and then what the tools are designed to guide from treatment planning and practice. And so most of us lack what's an adequate understanding of these screening tools and what they're intended for. Only 1 in 6 adults are talking with their healthcare providers about their drinking. So alcohol and brief intervention and brief counseling can reduce alcohol consumption by 10 to 30% in those that do drink too much. I'm talking about this because what we know is this critical intercept of screening and assessing that creates opportunities for us to create pathways of effective interventions. Oh, I still have, okay. So I will also talk about some of the data that comes out of. So screening, brief intervention, and referral to treatment. That's what SBIRT is. And what I will tell you is in primary care settings, it's been done for decades. We're seeing it more in justice legal systems. We're seeing it in educational systems. But in primary care settings, it typically yields a 75 to 90% negative response. So most people in a primary care setting might screen negatively. Those that do get a positive should be referred on for further evaluation and assessment. Let's translate that into some of the data that we know about our impaired driving population. And when about that 2/3 and the 1/3 that Dr. Nelson mentioned earlier, it's very, very similar to that population where 2/3 go on to self-correct, 1/3 do not. We want to be thinking that kind of correlation with the data with the negative and the positives. So some critical considerations. When most of the work that I've done with All Rise and Impaired Driving Solutions has been in the DWI court or impaired driving court realm, meaning we have done an incredible job identifying the high risk, high need impaired driver who requires the intensive services and requires the intensive treatment services. But what we have to be careful about is understanding that not all impaired driving offenders or folks are created equally. They do not require the same interventions. And so we have a publication about why DWI courts are not intended for the first time impaired driver. And for a number of different reasons, if you want more information, I'm happy to share it with you, but we can certainly over-treat and over-supervise. And we want to make sure that we are providing interventions that are clinically competent, meaning these are interventions that are indicated for the diagnosis, the severity of the illness, and have the intended outcomes. You hear me say this time and time and time again about the intended outcomes. And the intended outcomes are on the end of the spectrum when it comes to what are the interventions that create that. So let's talk what that looks like. It's through the safe systems approach, understanding, when we look at how NHTSA is appreciating all the different approaches that are necessary for our safe systems and appreciating that humans make mistakes and they're vulnerable. When we have that shared responsibility, we have to take that safety as a proactive measure, and then creating some of those redundancy opportunities. Who we know is at risk for DWI. Dr. Nelson talked a little bit about some of the mental health and substance use data. We also know when there's prior involvement in the justice system, also non-prior DWI involvement in the justice system, prior involvement with alcohol and substances, mental health and mood adjustment disorders, as we saw in the data. And then this population unique is they are resistant to and non-compliant with current and past involvement in the justice system. Said another way, this is a population that typically doesn't think they are within a criminal population. A little bit about risk, need, responsivity. Just, we can spend more time on this in a different time, but I just want us to appreciate a couple things. When we create opportunities for interventions, whether that's at our jurisdictional, our state, or even our agency levels, we want to make sure that we're in understanding who is in front of us, meaning we're matching the intensity of the intervention with the person in front of us. We want to understand what it is that they actually need, that we're targeting what their criminogenic and clinical needs are, and how we are responding to that. Are we tailoring the interventions to the individual's learning style, to their stage of change, to their culture, to their demographics, and to what their needs are? So it really is about the who, the what, and the how. We have to appreciate when we talk about the data and we talk about the sheer percentage of folks who come into our impaired driving realms with alcohol and substance use disorders or addictions. We have to appreciate what addiction is. It is a treatable chronic medical disease that has this complex interaction between reward circuitry, a person's lived experience, the genetics, and their life experiences. So when we think, about why people continue to do what they do, it has this compulsive nature, and they continue to use and continue to experience those things despite the harmful consequences. Understanding who's in front of us matters. The risk, the needs, the strengths, and the skills are all important, but they alone should not determine the service planning. The more we can prioritize what those needs, those skills, what those resources are to the individual, and they are matched to the individual, and more and client and patient centered, the better the outcomes. Now, I know the population I'm talking to. I'm well aware we are talking about justice involved, impaired drivers. I'm well aware of the dangers and the fatalities on our roads. I just want to be so clear about that. But what we are talking about is lasting change. This isn't, do you want fries with that, and not negating the accountability. This is understanding that not having uniform or arbitrary requirements and then wondering why they didn't have the intended outcomes on the other end is important to understanding how we get to an individualized approach. Because we do not have understanding addiction, understanding effective treatment, we have to understand it is not a one-size-fits-all approach. I know some of you have heard me say this before. I'm going to say it again. I might have some new people out there. In the state of Minnesota, where I live and where I started my clinical work, it was, and one of my very first assignments as a counselor was working with first and second impaired drivers, first and second of impaired driving offenders. And they would come in and they would get their screening and they would come in for a screening or an evaluation with me, but they would slide a piece of paper across my desk. It was from the DMV, and it said, in order to get your driver's license back, they had to complete 24 hours of relapse prevention treatment or 48 hours of intensive outpatient treatment. And they'd slide that little piece of paper across my desk and they'd say, hey, I'll take the 24 hours. Thanks for asking. I hadn't talked to them. I hadn't assessed them. We don't know if they have a diagnosis. I don't know what their clinical needs are, but I know what they need to get their driver's license back. And so the intent, let me be clear about this. The intent is that the people that need treatment are getting the treatment that they need in order to reduce recidivism, improve health outcomes, all of those things. But it was creating this one-size-fits-all approach. I want to be so clear, when we have that, it has these unintended outcomes because it is not a one-size-fits-all. We need varied levels of care. We need multiple behavioral therapies because it's not just substance use disorders. Don't we appreciate that with the data that we're learning? We have to appreciate that it might be multi-pronged and disciplinary, where we are using addiction medications, or we're using the guidance of our mental health professionals in the community. It is an entirely comprehensive approach when we are working with folks with co-occurring disorders, because there is no single treatment that is effective for everyone. This is, if you're going to snapshot a slide, this is one of my favorite slides. There is no single treatment that's effective for everybody. When we have arbitrary requirements, we will have we'll see the outcomes where about 2/3 are going to self-correct, 1/3 are not, and they are not having the intended outcomes. So much like when you go out to get your own services, whether it's to your medical provider or maybe you're getting help in your own areas, we want to know that the approach and what we're doing is working for us, right? There is no single treatment that's effective for everybody. Treatment needs to be readily available. It needs to be multidimensional, appreciating all the things that we now understand about the complexity of the impaired driver. There are no fixed lengths of stay. I've talked with a number of people over the last few decades. I mentioned I'm in Minnesota. It's the land of 10,000 treatment centers. We pride the work that we do up here in many of treatment agencies across the nation have been modeled after the work that we've done here. But I'm going to be very, very clear when we talk about days in treatment, hours in treatment, whether it's 28 days, certain amount of hours, certain amount of manuals. It is really, really clear that we know treatment needs to be, for it to be effective, it needs to be long enough, at the right frequency, at the right dosage, and with the right providers. So it isn't about the time in treatment, it's about the outcomes that are happening in treatment. And I know that most of you will appreciate this, that varies. And then we are continually assessing our treatment plans. We're making sure that they are adjusted to the severity and frankly to the improvements that our clients are having. So treatment plans are assessed and adjusted to the needs of our folks. It's shifting this model. So when I kind of talked about, I don't want to go backwards, but when I talked about program length. Historically, we've had how many hours, how many modules in this particular manual does somebody need to complete? That's really an acute care model way of thinking about this. There is no other chronic illness when we're talking about substance use, mental health, co-occurring conditions, a chronic health condition as defined by ASAM. We have to appreciate that's an acute care approach. There's no other chronic illness in which we're expected to have one treatment episode for 28 days and have somebody be perfectly well on the other end of it. If it were diabetes, hypertension, any of those other chronic illnesses, we are treated for our flare-ups, we are treated for our acuity of our illness as it is needed for the duration of our illness. And we will go through periods with our other chronic illnesses of managed or in remission. And when I become symptomatic, I need to go to my provider. So we're shifting this idea of acute care, one treatment episode, certain amount of hours and done, to really managing this through a more recovery management approach. We're taking it from I'm right, you're wrong, I'm big, you're small, to a client-directed management of their own long-term recovery. And I want to be so clear when I say this. Again, I know the audience I'm talking to. This doesn't mean that we're negating the accountability. It doesn't mean that we don't have the accountability factors, particularly with those that are justice involved, right? It just means we're really understanding that for this to be something our clients adhere to long term, it is really important that we're shifting this to a collaborative approach and offering those services. Because we shift from this compliance to the adherence. Our clients are, especially those that we've served in treatment, impaired driving treatment courts, or even many of the clients that have been in justice involved, are really, really great at compliance. They understand what I need to do. Like the piece of paper they slid over my desk for years. I'll just take the 24 hours. Thanks for asking. And so that's that compliance model. I'm not suggesting we don't have things clients need to do or our folks need to do. What I am suggesting is appreciating and understanding there is a difference between checking things off and returning to previous behaviors and concerning behaviors, and a difference with adherence, where we are genuinely understanding what the individual, their motivation is from an internal and an external resource, and what it is that will create that lasting change. So when change is genuinely happening in real time, we are more likely to create adherence than we are that compliance. When I first came into this field, this is what it felt like. It was very, very, Polo Mall, like that treatment plan. If somebody had said to me, I'll take 24 hours, can I do it in a weekend? Thanks for asking. And they met criteria for a higher level of care, I'm immediately at discord or at odds with the client. And this is what it felt like. It felt very, very, we got to bring them over. We have to make the changes happen. When we appreciate where clients are in their stages of change, and we understand how interventions, when they are tailored to a client stage of change, create those longer lasting outcomes and result in more of that adherence-driven change, the better the outcomes are for folks in engaging in treatment. Again, I just want to emphasize a couple things. We understand co-occurring disorders. We understand the impaired driver comes with massive complexities, right? From the comorbidity of mental health disorders to the comorbidity of substance use disorders. With proper screening, assessment, and treatment planning, we recognize this takes time. A lot of the folks that are going through treatment are going to need multiple episodes, like they would other chronic illnesses. And so when we talk about the intervals in which we're assessing and understanding the complexities of our clients, we're ensuring that they get the services that they need. We recognize that progress in recovery and progress in how this happens is often cyclic. It is not linear. It will have periods of remission, periods of abstinence, periods of treatment, and potentially periods of reoccurrence. In some ways, and there's some longitudinal research by William White, David Floss, and his folks, it can take significant amount of years for people to reach full sustained recovery. But what we are doing in our work, early screening, early intervention, early treatment for those with substance use disorders, is laying the foundation and the work that they can to sustain it long after we are no longer here. So when we go back to understanding what a safe system approach is, it really is appreciating that wraparound and habilitative services are absolutely key and fundamental. We know when we have the more services, and we understand who's in front of us, when the more services that we offer, the better the outcomes are for our folks. I'm aware of the population we are talking about. I am aware of the audience I am talking to. But when we think about how change really happens, and when we create those change trajectories for folks, it is when they feel heard, understood, and respected. Again, I want to be so clear. It doesn't mean it's negating accountability or any of the requirements that may come with this, but approaching this through that lens of understanding through compassion, empathy, acceptance, feeling heard, understood, and respected is how change happens. And then it starts to feel a lot like this. We're creating long-term change trajectories. We're walking along, and it's a collaborative approach. Dr. Nelson has a favorite quote. I have a favorite quote as well. It's an African proverb: until lions have the historian's tales of hunting, will always glorify the hunter. Oftentimes, I will sit around tables, particularly in treatment courts or even in clinical settings, where when the clients are doing what we want them to do, we pat ourselves on the back and say, yay, they're following our treatment plan. And when clients aren't doing so well, we put all the onus and the blame on the client. And when what this allows us to do and to shift our thinking is, are we assessing, are we screening for the appropriate mental health and substance use disorders, and are we ensuring that they have the proper and effective interventions to create that pathway? And with that, there's my contact information, and I'm going to turn it over to our Q&A with, I think, 2 minutes to spare.
Thank you all so much, Dr. Nelson and Julie. This has been great information for us. There are a couple of the questions that I can answer really quickly. There is a recording that will be going out either this afternoon or tomorrow morning. There is not a Spanish version of Cars Connect yet. We hope that at somewhere down the road, we'll be able to get that translated and have a Spanish version of the original CARS program. There is a Spanish version. And what was the last question? CEUs, we are not set up to handle CEUs in different states for those seeking continuing education. The big piece that I've seen in a lot of the questions has been about when to do it. If you go to responsibility.org, you can find a position paper there, but we feel strongly that screening and assessment should be done on first offense. When the person is first arrested, that they should be screened at that point. Many of them will screen out and won't need any help. Will determine they've just made a stupid decision, as we know a good percentage of impaired drivers do. But we'll also find out which ones do have significant issues, and we start addressing them then, not waiting for the second occurrence when someone may have been killed by that point, or other horrible things have happened, or the third or the fourth or the fifth, because we know that there are many times that people are driving impaired that there's no arrest made because there just aren't enough officers on the road. So this is something that we're looking at for first offense. It does not have to be used with a specialty court. It can be used in any setting where you have impaired drivers coming before the court or coming in, that you provide the screening tool, and you need to determine in your communities whether that's something that parole and probation can do, that's something the jails can do, whether that's something that the courts can do, where it happens in the process. But we want to look at all of the opportunities for providing a screening for mental health issues with impaired drivers. And I'm afraid we are out of time, and I don't want to take up anybody's time. So I thank you all for joining us. If you get in touch with us, we'll do our best to answer any of the questions we weren't able to answer in this brief period of time. I think that most of the questions that were posted were things that were answered later on in the presentation. So I think we did a fairly good job of that. Responsibility.org is thrilled to have you all join us today, and we're so grateful to Dr. Nelson and to Julie Seitz for providing the incredible information that they shared with you. Thank you.